So our next speaker is Jonathan Friedman, who is an American he's worked in Botswana, he's working in Cape Town with Médecins Sans Frontières, and his focus is at the moment on adolescents and HIV.
Thanks a lot for the invitation to speak today. I wish my talk was a little bit more upbeat, but it's a little bit more sobering than the PMTCT data. Unfortunately, adolescents are struggling a bit with HIV, and the numbers bear that out. I'm calling this talk a hidden epidemic because while a lot of people know about adolescents that they have HIV, the problem is actually getting a bit worse, and it's really time to act now. There are three sections to my talk. First, a little bit of background in epidemiology. Why is addressing adolescent HIV an emergency? And then talk about adolescent HIV care. What do adolescents want and need for their care? If we have a better understanding about that, then our interventions can be more successful, I think. And then just a few slides about MSF initiatives. What are we doing out in Kailicha to help address this problem? So firstly, just a few numbers. Adolescents are the fastest growing population with HIV. There were more than 300 new infections of adolescents in 2012. Unfortunately, it's the biggest group, the largest group cohort of people with HIV. In addition, they're doing particularly poorly. And while overall, if you take all ages, the mortality rate has decreased by 30%, which is fantastic news. If you look at the adolescent cohort, the mortality rate has actually increased by 50%. If you look at the ages at the times 2005 to 2012, the mortality rate increased by 50%, unlike all the other age groups. And as such, HIV-related deaths are now the #1 cause of adolescent deaths in Africa and the #2 cause of death worldwide. Why is this the case? Well, they are notoriously the most difficult. I have not treated a cohort of patients that's been more difficult to treat. They have poor adherence, they have poor retention and care, and as such, they fail at a very, very, very high rate. If you look at the suppression rates, they range from anywhere from 27 to 89%. And the failure rates are usually the suppression rates are about 40 to 50%. So when you think about that, 1 out of 2 of your adolescents that are on treatment are actually failing their treatment. And in addition, there's really high loss to follow-up rates as well, especially with kids that are perinatally infected. So what are the needs and what can we do for these adolescents and what's important to them? Because I think we need to start there. And thinking about this and researching a bit, I came up with 8 things that I think are very, very important. There are others, but these are the main 8 where I think that need to be addressed. 1, confidentiality, respectful treatment, comprehensive care and integrated services, competent, friendly staff, easy access to care, family planning, a youth-friendly environment, and I'll talk about that briefly, and peer support. So let's just go through each of these for a few minutes. The first one is confidentiality, and it is incredibly important to all adolescents, not just adolescents with HIV. They fear rejection, they fear being embarrassed, they fear family and peer abuse, and so confidentiality is really paramount when we're treating them. And the studies really bear this out. 14%, one study showed that 14% of youth did not receive the care that they needed for fear of not having for fears of concerns about confidentiality. Another study showed that while doctors they feel confident in doctors' confidentiality, they feared other people in the clinic were not going to hold their confidence. And that means it's so important that everybody who's working in the clinic, including the cleaners, the people who are working at the security desk, everything, the clerks, they are on board with giving comprehensive and confidential care. And what's also important is that teenagers have an opportunity to speak individually with their healthcare workers. And teenagers that did not have that opportunity were less likely to bring up sensitive concerns. The next one is respectful treatment. They're very sensitive creatures, these adolescents, okay? They're sensitive to rude, judgmental behavior and attitudes from staff, and the studies really show that such attitudes can cause poor adherence, can cause poor attendance to clinics. Comprehensive care, this is a huge one, as well as integrated services. adolescents want to have it as easy as possible, as do all the patients, no matter what their age. And that means having a multidisciplinary approach to their care. That means having primary care, reproductive health services, STI, and HIV treatment, substance abuse treatment, mental health, and access to TOP all in the same center. And there's an added benefit to this as well, in that it can decrease stigma. And adolescents, you hear a lot, they like it when they don't really know why other people don't really know why they've showed up to the clinic. Okay, they tend to like that. The next one is competent staff, a diverse, friendly, and well-trained staff, okay? And here's this term youth-friendly again, and youth-friendly services with healthcare workers who are sensitive to cultural differences. And if we are not sensitive to their cultural differences, it's been shown that categorizing, stereotyping can be barriers to effective treatment. I came across one interesting study about, specifically about interpreters, and the need to have interpreters, and the lack of interpreter services can be associated with patient dissatisfaction, poor comprehension, etc. And this is just getting to the point that it is so very, very important to communicate well and clearly with our adolescents so that they understand what our treatment plans are. Another really big one is easy access to care. I just mentioned how adolescents really want to have it as easy as possible. And unfortunately, there are lots of barriers to this. Transportation issues, difficulty appointment times, school conflicts. Okay, so it's very important to have your clinics for adolescents be sometime in the afternoon. Not knowing where to go is a big one. And this just doesn't mean, not knowing where to go to their local clinic, which hopefully is near their home, but if you have to refer a patient, for example, to Tygerberg or Hertescure, you need to give them very good instructions as to where to go. These buildings are enormous, specifically, particularly I think Tygerberg is just an unbelievably huge building. If I was giving this talk in Tygerberg, I'd say Hertescure. So. And other things, difficulty scheduling and keeping follow-up appointments, returning for tests. Obviously, if we can combine appointments and not have them keep coming back, again, making it easier for them. Family planning and reproductive services. This is a service that they really need and want. They certainly do need it. Teenage pregnancy rates are very high. STI rates are very, very high. And again, getting back to the importance of communication, an interesting study showed that half of unintended pregnancies occurred among contraceptive users, and that 90% of these resulted from inconsistent or incorrect use of the method. So they were getting their contraceptives, but they just didn't know how to use them. And so we weren't doing a good enough job here in actually explaining how to use the contraceptive methods. This term youth-friendly environment is being seen and heard more and more these days. And I couldn't find any real studies on whether it makes a difference, specifically youth-friendly environments and youth-friendly clinics. But I can tell you from anecdotal evidence from our clinic, our treatment failure clinic in Kailicha, and some web-based material, that they really do like it. They like adolescent decor, materials. They think it's an important aspect of their care. And also adolescents are often sicker and sometimes make unsolicited advances. So they like having their own space. I think about the Ubuntu clinic in Kailicha, which is an excellent clinic. They do really good care there. But it's kind of half inside, half outside, so it's really cold in winter, really warm in the summer, and there's just benches. And if you put yourself in the shoes of a 14 or 15-year-old, what 14 or 15-year-old or 16-year-old is going to want to go to Ubuntu, sit on a bench next to a 70-year-old man who's coughing and has TB? They just won't go, and they don't show up. So I think we need to do a better job in providing spaces. It doesn't have to be their own building, but at least some space that's specific to them. The last one here in this section is just talking about peer support, and even the WHO comments about peer support, and that it provides many benefits. It's a source of psychological support. It helps to build confidence and reduce anxiety, promotes a sense of belonging, and a source of practical information and increasing motivation. And we've really seen this in our teen clubs and our support groups that we've had as part of our treatment failure clinic. They just love it, and the idea, the feeling that they're not alone anymore going through this disease with other people who are sharing the same experiences is incredibly helpful for them and a very powerful way for them to learn. Okay, and then just lastly, just for a few minutes, I want to share some of the experiences that MSF has had out in Kailicha with adolescents. The first one is the Pediatric Risk of Treatment Failure Clinic, and we don't call this that to the patients. The patients don't know it as a treatment failure clinic. We call it the Zatembe program, and this has been going on for about 3.5 years. Zatembe means believe. And what is it? Well, it's a dedicated approach to treatment failure, and it is comprised of many things, but the two major ones are individual adherence sessions and a teen club or support sessions, and that's kind of the core of the program. And that's really worked very, very well. We've had really very high rates of resuppression. About 75 to 80% of the kids that come to the clinic resuppress their viral load. What didn't work with this is when we tried to have schedule actual, exact times for them to come, because let alone coming, they're not going to come at exact times, let alone the same day. And so that really didn't work. And so we have to be cognizant of that. It's difficult. We can't treat any of the adolescents unless we can find the adolescents who are HIV positive. And this is a program that we started last year. It's an HIV testing program, not just for adolescents, but for kids 0 to 19 years of age. What is it? Well, it's a provider-initiated testing and counseling program, or a PITC program. And it's really a simple program. It's a clinic-based program where we give a 5 to 10 minute waiting room talk, and then hand them this flyer. And then the flyer says, "I am interested in testing, please tell me more." They bring this flyer to their healthcare worker, and it starts a conversation. And it also prompts the healthcare worker to discuss testing with them and how important that is to test. And it really did work in terms of increasing testing. We doubled the amount of testing over an 8-month period compared to the previous year's 8-month period. What didn't work is that we didn't find that many adolescents with HIV. And there are many reasons for this, and we could have a long discussion about it, but one of them is that our PMTCT program is very good, so maybe the adolescents aren't there anymore. Maybe they've moved away from Kailicha, or maybe that the ones that are more likely to be positive actually aren't going to clinic, and we need to look elsewhere for them. So what are we going to be doing in the coming years? This is one of the things I'm very excited about is our adolescent mixed clinic, and we're calling it a mixed clinic because we're combining stable and failing kids. Previously, our treatment failure program is just failing kids, but we're now combining stable kids with failing kids, and hopefully they'll learn from one another. We're going to give clinical care, individual counseling again, and support groups, and start a buddy system, a peer-peer mentoring system. This can lead into a peer-peer contact tracing program as well. So if one of your buddy doesn't show up to clinic, it's part of your responsibility to go find out what happened to him. Why didn't he come back to clinic? How can you help? And so you have a peer-peer mentor. Other things that we want to have as part of this clinic are career exposure sessions. I've been having some interesting conversations about what does it take for these adolescents to change their behavior, because we're trying to change their behavior a lot, okay? And just yesterday I had a patient who came in who wasn't forgetting to take the medicine, he just didn't want to take it anymore. And trying to convince him that it's important to take the medicine is very hard. It's very hard to change behavior. And maybe one of the ways to change behavior is to get them excited about different careers. A lot of them aren't exposed to a lot of things, especially out in Kailicha. So inviting a policeman, a fireman, a doctor to come and speak about what is entailed to becoming that specific vocation, maybe that will help. And then, of course, group outings are very helpful to bring strictly social things away from the clinic. Very helpful. Getting to the testing question again, adolescent mobile services. This is tied into our adult mobile services, which we're going to be starting. This is a little bit like the tutu truck. I don't know if you might have heard of the tutu truck, which we're going to be giving HIV testing as part of the service, STI screening, family planning, and some termination pregnancy screening as well. Basically parking this at hotspots, trying to find these patients who aren't going to the clinic, and how can we then find them in these kind of harder to reach adolescents. And then just lastly, I think it's really important for us to start to communicate using the methods that they use to communicate. God forbid we ever try to call them anymore. They don't really answer the phone. We need to text them. We need to get onto WhatsApp groups. We need to get onto Facebook pages and start those. We need to start to use, I think, virtual technology for our education. I think the days of the flip file, the flip folder, while still good in some cases, might be a thing of the past, because I think we need to find better ways that we can educate them through their phones, mobile apps, and things like that. And then lastly, anything that we can do to bring them back to clinic and keep them coming back to clinic is great. I think needs to be done. So even things like free internet, we should maybe even consider. And that's it.